Hello, I'm Mikko Luostarinen. I'm a doctor here at the Helsinki University Hospital at the Department of Clinical Neurophysiology. And the study I'm introducing for you today is a part of a project of collecting reference values for motor evoked potential exams at our department. The motor evoked potential exams, or MEP exam for short, use transcranial magnetic stimulation, or TMS, to elicit peripheral motor responses and can be utilized in diagnostics to assess the function of a patient's motor pathway, for example, when upper motor neuron disease is clinically suspected. Diagnostically, the single most useful variable obtained in an MEP exam is the central motor conduction time that has been shown to increase in central motor pathway lesions. It can be measured with single pulse TMS by first measuring the total latency between cortical stimulation and distal motor response, and then subtracting from this the time between nerve root level stimulation and distal motor response. By contrast, the amplitudes of MEP responses are not as useful in diagnostics, because they have a lot of inherent variation between individuals and also between tests. Indeed, many factors can either facilitate or inhibit the MEP responses that depend on the pre-stimulus excitability levels of neurons in the motor cortex. Using a paired pulse TMS, it's also possible to assess this so-called intracortical inhibition and facilitation during the MEP exam. In paired pulse TMS, a sub-threshold conditioning stimulus is first given below the patient's motor threshold prior to a larger supra-threshold test stimulus that is then intended to elicit an MEP response down the motor pathway. The amount of intracortical inhibition or facilitation you'd observe with this depends on the interstimulus interval between the two stimuli. Inhibition has been shown to be most prominent after 2 to 3 milliseconds of the conditioning stimulus, and facilitation peaking at about 12 to 13 milliseconds after the conditioning stimulus. The facilitating paired pulse can also be used in cases where you are unable to elicit reliable MEP responses from single pulse TMS, even with the maximum intensity of the magnetic stimulator. However, in clinical settings, our experience has shown that sometimes even with a paired pulse stimulation, it's sometimes hard to elicit MEP responses from some patients. This is particularly the case in lower extremities, in older patients, and in patients who have a pathology of the motor pathway. So, another way to facilitate the MEP responses is pre-activation. In other words, the patient voluntarily contracting the target muscle while given the TMS stimulus. The amount of facilitation depends on the intensity of the muscle contraction and can be even more effective at facilitating the MEP response than paired pulse. But in clinical setting, there are sometimes problems when using pre-activation technique. Firstly, it requires the patient to be able to control the target muscle with somewhat precision, which is not always the case. Secondly, because of already present muscle activity at baseline, it can be difficult to accurately evaluate the exact starting point of the MEP responses, therefore possibly resulting in less reliable estimates of the MEP latency and of the central conduction time. So, in this study, we aimed to solve this problem by using two sub-threshold conditioning pulses paired prior to a third supra-threshold test stimulus. We call this technique the double facilitating triplet TMS. The idea is that by giving two conditioning stimuli with a suitable interstimulus interval below the motor threshold, you can further increase the amount of facilitation compared to a simple paired pulse with only one conditioning stimulus. Using a technique like this has been prescribed earlier, at least in 1996, by Zeeman, Rothwell and Redding, but to our knowledge, its use or benefits in clinical diagnostics have not been reported before. This also should not be confused with the triple stimulation technique, which uses two electric peripheral nerve stimulators and a collision technique, together with TMS. Going over the technical details of our study, we had a sample of 50 volunteers who were between 24 and 70 years of age and healthy in the sense that they had no epilepsy, no medications affecting the central nervous system, and no pathologies of the central or peripheral motor pathway that we knew of. The test equipment used was a BrainSTIM 3-in-1 stimulator with a monophasic pulse, a round coil, and maximal power of 2 Tesla. MEPs were measured from target muscles with surface electrodes using a clinical ENMG system. The abductor pollicis brevis was used as target muscle in the hand and the tibialis anterior in the leg. Electric stimulations to median and peroneal nerves were first used to exclude peripheral nerve block. Then, with single pulse TMS, the optimal transcranial stimulation spot was located and the motor threshold value, later called MT, was determined as the lowest stimulation intensity that produced MAP responses with peak-to-peak amplitudes of over 50 microvolts in at least 5 out of 10 stimulations. 5 single pulse measurements were then carried out with stimulation intensity relative to 120% of MT. In addition to single pulse measurements, 5 measurements of facilitating paired pulse and facilitating triplet pulse were conducted. An interstimulus interval of 13 milliseconds was used between all pulses, with stimulus intensities of 90% MT for the conditioning pulses and 120 of MT for the test pulses. Mean amplitudes were then calculated from each 5 measurements, including possible zero amplitude ones. Okay, so the results of the study showed that triplet pulse TMS produced MEP responses of significantly higher mean and median amplitude than either single pulse or paired pulse TMS in both target muscles. The increase in amplitude was more substantive in the leg. Also, we observed 2 instances in our healthy test subjects that a single or paired pulse TMS failed to produce any reliable MEP responses, but triple pulse succeeded. In this graph, you can see the mean amplitude distribution of each 5 measurements with single, paired and triple pulse in both target muscles. Outlier values are marked with dots, the middle line is the median, and boxes represent the upper and lower quadrants of the distribution. All of the differences between the mean amplitudes were statistically significant. Additionally, we observed that the amount of facilitation on MEP amplitudes between paired pulse and triple pulse had a strong, almost direct correlation. This was the case in both the upper and lower extremities. In these graphs, you see function of the relative amplitudes compared to single pulse amplitudes of paired pulse and triple pulse. And as you can see, on an individual level, the relative rise in amplitude between paired and triple pulses is quite comparable. Also worthy of note is that both paired pulse and triple pulse TMS significantly shortened the MEP latency compared to the baseline single pulse stimulation at 120% of MT. Here you can see the mean latency times in single, paired and triple pulse measurements for both target muscles. So, from the results we conclude that in this relatively large sample, facilitating paired pulse TMS and facilitating triplet pulse TMS showed to be more efficient in producing MEP responses than single pulse TMS without pre-activation. Furthermore, the double facilitating triplet pulse TMS can be applied in the clinic and might even be a more reliable method than paired pulse. The amount of facilitation observed seemed to be correlating with paired pulse individually, so the double facilitating triplet pulse TMS could probably be used to assess intracortical facilitation as well. It also could possibly offer some novel diagnostic correlations, but further clinical testing on patients would be needed to study this. It would also be interesting to do a study comparing the latency estimations and amplitude values of MEP responses when using the triplet pulse TMS or the pre-activation technique to produce facilitation. Finally, when comparing results to reference values obtained with single pulse stimulation, the shortening effect on MEP latency should be accounted for when using double facilitating triplet pulse MEPs. Okay, thank you for your time. I hope you were at least somewhat brain stimulated.